Good evening, everyone. It's my great pleasure to welcome you all to the University of Melbourne and to this, the third event in our 2022 webinar series, which is focusing on participatory approaches to health research, the art and science of effective partnership. My name's Marie Gertz and I'm Professor and Head of the Department of Nursing at the University of Melbourne. I want to begin, as always, by acknowledging the traditional owners of the land on which I'm working today, the Wurundjeri people of the Kulin Nation, and pay respect to the Wurundjeri elders and their families, along with any Aboriginal or Torres Strait Islander people who are with us online today. Now, I'll just say a little bit about the event series before we get started. So for the first two events, we were really privileged to have Professor John Olive come and speak to us to open the series, and John spoke on photo voice, Zoom interviews and digital storytelling, and presented this as a qualitative health trifecta. We had the Marion Barrett lecture in May, and that was Professor Leanne Aiken, and Leanne talked about embedding consumer participation in research. And then that was followed in August by Professor Maya Christian-Sami on influencing cancer policy and practice through co-design. So thanks so much, everyone who's been able to join us for those webinars and our in-person Marion Barrett lecture in May. And this is the final event of our series for the year. And tonight we're going to be hearing from our colleague, Associate Professor Bridget Hamilton, who will deliver her webinar on methods for partnering well with consumers in our research teams. And she's talking about climbing Arnstein's ladder. So I'll just give you a little bit of housekeeping before we introduce Bridget formally. So please make sure that you will be automatically muted and you'll have your cameras off. You can see down the bottom of your screen, you'll have a Q&A box, and you can submit questions at any time during the webinar to Bridget, and we'll have time at the end to answer some of those questions. We'll endeavour to get through as many as possible. And we've got Teresa Kelly from the Centre for Mental Health Nursing, who's going to be helping us to manage the questions as well. The webinar is being recorded, and that'll be made available to everybody who registered for the event. And there'll be some post-event communications as well, where we'll ask you to fill in a questionnaire about your satisfaction with it and any suggestions you have for future. So you can also join the conversation by tweeting the hashtag 2020 Nursing UOM. So please do tweet away. So now, without further ado, it's my pleasure to introduce our colleague and friend, Associate Professor Bridget Hamilton, who is Director of the Centre of Mental Health Nursing at the University of Melbourne. She leads a team of clinical nurse academics and consumer academics building up skills in the contribution of mental health nurses across Victoria for the benefit of people receiving mental health care. Her scholarship is about maximising effective engagement in supported decision-making in mental health care settings. She's building leadership and research capacity in mental health nurses and in the consumer workforce. Her program of work is translational in nature and spans acute, emergency, community mental health services with the aim to implement and sustain evidence-based interventions, including safe wards and sensory modulation. Her research expertise covers ethnographic field work in healthcare settings, knowledge translation, program evaluation, discourse analysis, and narrative approaches. And a really important feature of Bridget's work is partnering well with consumers. So I'm warmly welcoming you to this evening, Bridget. You're in the Netherlands. Welcome. And thank you so much for presenting this fourth webinar.
Oh, thank you so much, Marie, for that introduction. And I am absolutely delighted to be speaking with you all this evening. I feel that I'm in rather impressive company for this event series, so I'm hoping that I can do justice to the topic and rounding off the series around participatory approaches to health research and the art and science. And I did review the other presentations from earlier in the year as part of prepping myself for this evening, and I would like to encourage anybody here who hasn't seen any of the three previous lectures to take the opportunity to watch the recordings, because they were really excellent and really inspiring. So it's been terrific to date, and hopefully I can make a good contribution tonight. So let's dive in. The next slide, please. The picture I have here is the most recent picture we have of my team at the centre. This was taken at our annual conference in August, and we've only got the 3 nurse academics here and 3 consumer academics, ably led by Vrinda Edan, who's the Consumer Academic Program Coordinator at the centre, and also our trusty comms admin events professional staff member. The missing people from our picture here is our exceptional RA and a number of other academics in small fractions, both nurse academics and consumers that contribute to the work of the centre. Talking about, co-production and participatory approaches, I could be co-presenting today, and that would probably make sense in many respects. However, it is a seminar, and I'm really going to be speaking to you with my sort of take on the work as a mental health nurse myself. And yeah, hopefully that's going to be a contribution that, as we say, rounds out the series well. Next slide, please. What I'm hoping to do today in this, this talk is to offer you something of a survey of the partnership research that I've been engaged in over 15 years or so, and thinking about research and academic writing, both as co-working strategies, both in the research and in the writing in the mental health field. And I want to place this work, first of all, in the context of Arnstein's ladder and the concept of co-production. So I'll just have a brief introduction to both of those things. Then I'll be thinking about what is the outcome or the impact of those types of work, and looking at some of the concepts and the findings and the impacts of a number of pieces of research. And in talking about that, I'm particularly focusing on methods or some of the practical strategies that we've employed to really foreground consumer voice and to pursue equity and to build a solid co-productive team and strengthening that over time. And of course, this is an area of considerable debate and development. And so this has been definitely a learning process for me and for our team over time. So hopefully I bring that kind of humility to the fact that it is we are work in progress always. I also just wanted to touch on a sort of reflection, because of the series, about why these practices of partnership might be quite prominent in nursing and nursing as a discipline, what that connection might be about in terms of particularly proximity and partnerships. Next slide, please. Let's dive in to the work of Arnstein. As soon as you're looking at a ladder like this, obviously there's an assumption in the concept of a ladder that it's good to go up, onwards and upwards. And I'm sure people in this space are familiar either with this ladder or other ladders of participation. There's certainly been conversation about it in the series and just generally in the research field. Other versions of the ladder of participation might use different terminology, and certainly one of the first things I notice with Arnstein's ladder is some, if you like, uncomfortable language features, potentially. So particularly thinking about non-participation and low rungs of the ladder, manipulation and therapy, those are fairly confronting terms, and also the notion of tokenism, which I think is very familiar and has been touched on by a number of our speakers, the potential that our work for all of the good intentions might end up being tokenistic is something that's very present in the discussions around participation. And then the concept of a citizen control is probably something that's a bit distinct to Arnstein, and the concept that co-work does rest on robust partnership, so placing work higher up this ladder in potentially than other strategies. And I just thought, because of the nature of the language in Arnstein is as it is, I might bring people into the picture who might not be familiar with Arnstein as a person a bit more, and I explore that a bit myself. So Sherry Arnstein, writing this work in the 70s, had trained as a PE teacher originally and had undertaken a stint of work as a caseworker in youth justice. These were her formative work experiences. She'd then undertaken a communications master's. And at the time of writing this very influential work in the mid-70s, she was a senior bureaucrat in the US Department of Health, Education and Welfare. And her main project work at that time was around desegregation of health. And obviously this is a very meaty and difficult field, but it brings forward the considerations around very significant harms associated with marginal groups being treated differently, discriminated against in healthcare. And so she's not pulling any punches as a voice into government, and also having seen some of the very negative impacts of power over, that had obviously been a very significant part of the work that she was familiar with. You know, I think there is a potential for all of us, though, to notice how much rhetoric there can be around citizen participation, a lot of euphemistic language and intentions and so forth. So I think probably we can all relate when we think of any situations of marginal positionings of voice. And so there's some merit in sticking to the tried and true or the original, in my view. So there we have a little bit about Arnstein and the ladder. Next slide, please. Also wanted to bring forward, there are many, many voices in the space of co-production, but this work by Edgar Kahn has been quite influential as well. And co-production as a concept isn't there in the words in Arnstein's ladder, but was definitely part of public health discourse and actually economics discourse in the 70s, particularly in the US, but also in Europe. And then Edgar Kahn put together this very influential piece of work, and I would like to commend to people the Vimeo that I've noted there. The Parable of the Blobs and the Squares is a section in the book, and the animation undertaken in the 2000s is a very accessible description of some of the key elements of co-production. So Googling Kahn and Vimeo and the Parable of Blobs and Squares, it's 5 minutes well spent to check that out. If we just think about the content of the book, next slide, please. The assumptions that Kahn makes explicit around co-production, I've listed here that firstly, moving slightly from some of the more depersonalized, if you like, economic benefits to this notion of recognizing people as assets is quite central to the thinking around co-production in health and social care, especially. Thinking about people as the real wealth of society is a different way of thinking for economists, potentially. And similarly, thinking about work and contributions differently, and recognizing and valuing contributions that aren't always associated with financial transaction, looking after people, social justice, good governance, raising families, all of the work and all of the people as assets. So there's a kind of sense there in those two values about rethinking what counts as and what is valued, what matters. And this is true for us in academia and in healthcare as well. And then the second set of assumptions there, promoting reciprocity, giving and building, and the value, giving and receiving, and the value of that to build trust between people and mutual respect is a value inside co-production. And similarly, beyond the idea of building social networks as well, and the value of the purpose of wellbeing being quite dependent on relationships, not just within, say, a marginal group, but across the co-working groups, and really foregrounds relationships. So both of those, promoting reciprocity and building networks, really foregrounds relationships and the value of investing in these. So these are some of the assumptions that do sit behind the co-production work that we do, and that I think is relevant for the series. Next slide, please. Coming closer to home, we have this excellent resource for co-production in mental health settings, and a shout out to, in particular, next slide, please, to Kath Roper, who is the first consumer academic in Australia, and has a long-standing appointment at Melbourne University. And I think it's essential to mention Kath as really, she's been a key partner in most of the co-work that the centre has done, and most of what I'll talk about this evening, if not all. And that relationship between us and with other colleagues in the centre has been pretty fundamental to the program of co-producing work and thinking about it, and to me, actually, in my career. And it's a great resource that is quite widely downloaded and used already in the mental health sector, across the world. And there's this statement inside the reference. The most important part of co-production is shifting mindsets and establishing a culture that embraces exploration and learning and genuinely values consumer knowledge and expertise. And I think that statement does reflect those Kahn principles or assumptions well, but also it foregrounds this idea that maybe the co-production and these applying these values is a change, is a shift in mindset. And I think that's a reasonable observation also. Next slide, please. So given that co-production isn't named by Arnstein explicitly, I think we can see that we're wanting to locate work up high up the Arnstein's ladder as co-production in those top rungs. And in a lot of ways, there's an invitation for us all to test our co-work and our partnerships and see where we're landing. And if we are landing here, locating, discussing and debating the merits of participation work. And so that's, what we'll be thinking about in the practical examples that we're now going to consider. Next slide, please. So the rest of this seminar is really working through some examples, and I'm choosing to present, I guess, 3 different sort of chunks of work and talk about them. And the first is about the issue of co-authoring. And in particular, we've been engaged in co-authoring a number of literature reviews and conceptual papers. And we've invested in a strategy which we're calling polyphony. And I thought that might be interesting for people to hear something about. And then moving to more empirical studies that we've been engaged in the co-work there, first of all, co-investigating consumer experiences of service, and then moving to co-evaluation of programs of work and making recommendations for practice and service system change. So that's where we'll be heading next. Next slide, please. So if we dive right in. The first experience that I had of co-writing together with Kath came out of a conference presentation that we did. So Kath and I went to a conference in New Zealand and presented on our thoughts about insight. It's something we'd been discussing and working with as part of our teaching co-work. So Kath is a consumer academic running the consumer perspective subject in the graduate diploma, and me coordinating the program at that time and teaching into other subjects, were really struck by the problematics of the word insight and the term and what it stands for. And so we had presented at the conference side by side, and we didn't make an effort to say the same things or to check each other's kind of contributions so much as just to be speaking in a kind of a exchange between us. And yeah, we really enjoyed doing that work. And then the chair of the conference came and spoke to us afterwards and invited us to submit a paper to an issue of a journal that he was editing. And so we did work this up into a paper. And basically, this paper was a critical analysis and commentary on the application, the use of the term insight in mental health settings, a critical analysis of quite a lot of papers, seminal papers on insight. And that was fitting for me in terms of some of the analytic tools that I was using in my PhD at the time. And Kath also bringing a consumer critique and a critical social critique also. And in the writing, we didn't attempt to make one coherent voice and homogenize into a sort of one piece of writing, knowing that this topic of insight is suffused with the exercise of expert power. We were really enjoyed both the critique of that, but also the potential to stand, for a consumer perspective, to stand clear and singly. And so, yeah, we had a section of the paper that Kath wrote independently, and just this is a little trick, core aspect of the paradox that Kath was exploring around the way the concept of insight positions consumers. The only way I can demonstrate insight is to say that I know I'm sick. To do this, I have to show that I am aware that when I am sick, I am not aware that I'm sick. So you can see how that owned voice is quite clarion, a really clear bell-like expression about the impact of the use of the term insight. So that was our first go, and thinking about plural voices within our writing. Next slide, please. What are we up to? Maybe 16 years later, a fairly recent piece of work that we did, that we employed this co-writing and polyphonic mode of writing. Again, we've explored it in policy documents and reports, and here's another a publication, this time with a larger co-investigating team. So Lisa Brophy led on this work along with other academics, and we were looking at the literature around how design in inpatient settings could enable less use of restrictive practices, seclusion and restraint. And we had 2 consumer co-authors as part of the team, and again, sections that were written very specifically in that voice. It was certainly obvious to everybody, next slide please, that everyone could see that consumer voice is lacking in the publications, in the analysis, in the critique of the design of inpatient settings, and that's clearly, a lack that's quite limiting to that type of research, since these are the people who are having experience of that space. And then this was a significant passage in the conclusion that was co-written by Kath and Kat Minshall, or Kath Brazier now, as the consumer perspective co-authors. I'll just let you read that. So I can say that we find this concept of writing side by side and allowing voices to stand independently as really interesting and potentially powerful for things like curriculum review or literature reviews. And if there's not other ways in which we put consumer leadership forward, then at least an independent and unalloyed voice is we feel quite a fresh and potent method for bringing forward that perspective. And what we are doing different here, I think, is incorporating voice without editing, homogenizing difference, harmonizing key points, because there's not always agreement. And so let's not pretend that there is the case. But in addition to that, I've been really struck by the thinking work. Several consumer-led conceptual theoretical papers show the extraordinary contribution of a consumer lens on work. It makes a very substantial and sort of fearless contribution, which I find very compelling. And of course, as a nurse academic, my contribution is often, if that is the voice that's foregrounded, to also think, well, how might these insights be taken up and shape nursing practice, and what could that look like, and how, knowing as I do from a nursing academic perspective, what practice is. So there's a real place for partnering, we feel. Next slide, please. So moving on from the core academic art of writing to the empirical research and co-producing empirical studies, the first significant piece of work that I wanted to share with you involves recruiting a consumer investigator as part of a research fellowship, a capacity building fellowship that the Victorian government offered in the early 2000s. And as part of we were undertaking a local evaluation of Rapp and Gosch's strengths model of case management at St Vincent's at the time. And in proposing, requesting or seeking a grant, we determined that there'd be value in producing consumer narratives of their experience of working with case managers as a key element of service evaluation, and that it would be more powerful and also a great opportunity to build a fellowship into this project. So obviously, it means that the initial work on the grant was written, by me before we had funding for additional team members. But the successful fellow, once we got the fellowship, Evan Bashara was as a consumer consultant and experienced worker in the field, became the primary investigator. We also had other members of the team, an academic linguist who we brought in to support the novice work of a qualitative researcher, for Evan to be in that role, especially in interviews, but also in analysis. And also, even in the design stage, we had the benefit of consumer academic advisors. So Kath Roper's group of advisors at that time, the PAT, Psych Action Training Group, was a sort of brains trust for the role that she had at the university. And we included a team of up to 4 consumer investigators in various aspects of particularly analysis. And we only had 2 clinicians and then the support of another methodologist. So it was a fairly consumer-loaded team. And what else to say about that? And I think we'll move on to next slide, please. what did this study produce? Well, if I just put forward an example, we were able to recruit 20 people who had a long experience of mental health service use, including experience under the Mental Health Act, and were then part of these fairly intensive case management services, community care units, and mobile support and treatment teams. So not necessarily considered a sort of a typical sample of, rich informants. And it was definitely significant that people were recruited through the work of a consumer perspective researcher. There's no question in my mind that different people came forward because the invitation came from someone from a lived experience perspective. And here we have Evan asking the question in the interviews, I haven't had a case manager, I've only had a private psychiatrist, I'm interested in what it's like to have a case manager, how are they relating to you? And Terry's response, all the case managers I've had in 10 years, about 5, all of them have been really good except one. There was definitely a frankness in the way that the interviews flowed, in addition to the fact that people were recruited who I would propose might not otherwise have joined the study. So yeah, there's a quality to this research that was quite distinct to me. If you want to, next slide, please. And then when we went through the process of analysis, thematic analysis and narrative analysis, the themes that came out of this study included, when the relationship is good, what that's like, the value of easy access for support, the importance of practical doing with strategies valued by consumers, the experience, really interesting experience of motivating, case managers motivating and pushing, which we explored in some detail, the need to improve a role with medication, that was the point of greatest dissatisfaction, and the value of sharing information and doing that more. These were the key themes. And just to give you a flavour of that, around that interesting topic of motivating, we've got one extract there. Sometimes they push me and sometimes I don't like that. Sometimes I do. It depends on how I feel on the day. So a sort of mixed feeling. And then another interview, another participant said, he's good at motivation and stuff. Oh, how does he motivate you? Just compliments and stuff. Yeah, sort of a bit of pushing as well, which is good. So it was a very interesting finding. But yeah, these were terrific, rich, qualitative interviews. Next slide, please. We we undertook thematic analysis. We also undertook narrative analysis, and each of the individual stories were summarised into a narrative summary. And this is a summary that Evan wrote around the experience of Matthew. So I'll let you read that. What I'd like to emphasize here or unpack a bit more, though, is the strategies that we used to make this experience of co-work as strong as possible, to improve the quality and to bring equity into the space for having a novice primary investigator, and how to support that person and that voice to be as potent as possible in the study. So clearly we had co-authors in the final output, which is the book in the corner, but we also, making a decision to have this majority of consumer academic team in the project was a very distinct intention, so that we didn't have that experience of someone being isolated in their role, or even being isolated in their research perspective. And methodologically, having a coach who is not in a clinical discipline, but somebody who is methodologically very strong, and particularly having a linguist who had done intercultural linguistic studies, really sensitized that. Meant that person was sensitized to perspective taking and cultural difference, and was a really great resource in that space. And then how we undertook co-analysis. So if I can just describe the process of analysis. When we were undertaking that narrative analysis, we all listened to the audio and read the transcript together as a group, and then we discussed what we thought were the hot spots in that particular story, and out of that discussion took notes, and then one in the group would decide to summarize. So there was a kind of equitable democratic sharing of who took the lead on that writing as well. It's been my experience that with some of the teams I've worked with out of Europe, that it's common to have an anthropologist or a medical sociologist within healthcare service evaluation teams. And for instance, I belong to the European Violence in Psychiatry Research Group, and there are a number of health sociologists in that group. And I don't see that as common in our services, but I think it's really potentially enriching. And obviously, this idea of co-analysis and the narrative analysis to intensify individual stories, that group always had at least 2 consumer academics in it. And as I said, we took turns in narrative summarising. So they're just some of the strategies we employed that might be of interest. All right, moving on to the final study that I wanted to bring to your attention. And kind of ironically, I'm talking about safe wards here. I feel I've lived safe wards a lot over the last 10 years, or maybe a little bit less. But the work I want to talk about is probably the weakest example of co-production, because, well, it is, and I'm just owning that, but also what we're seeing in a program of work is some mixed forms of co-work. And in that sense, it's probably a real world example for people. This is work in the area of safety and the reduction in the use of restrictive interventions. And you can see on the screen there the UK-based resource kit, and then in the foreground a revisiting of some of those resources in the Victorian resources for implementation of safe wards. And that's significant because there was very significant consumer contribution into some of that refinement and implementation and training and so on. So it was a consumer perspective was very present in different levels of that work. Many consumers do have an interest in research and strategies which are aimed at changing culture in inpatient settings. And safe wards is appealing to me and can be appealing to others because of it does tend to use quite a lot of lay language and non-blaming, even though this is the really pointy end of practice, and also acknowledging the impact of the context itself on what things that go on. So if we move to the next slide, we can see this is what's called the simple model of safe wards. And in this model, it's a linear model. You can see that there's a safe wards is both a model and a set of interventions, 10 interventions typically. And there's a kind of progression from the idea that maybe some things in the context, originating domains, not just the person, but staff, the legislative context, the physical environment, might all have provocations in them that potentially lead to flashpoints. So points of tension, and out of a flashpoint there may be explicit conflict of some kind, and when conflict occurs that may also be responded to with containment or restrictive practices. There might be other ways of thinking about containment as well. So containment is probably the only term in that model that might not be really common usage, but restrictive practice is the thing that safe wards attempts to reduce. And then, as you can see in the model, there's a role for patients or consumers in influencing the model, influencing that trajectory. And so patients might be, intervening for themselves, caring for themselves, doing things, but also with each other that might help diminish the potential for a flashpoint, and might also help after a flashpoint that conflict may not occur. So this was the way the model was devised to see that role. And of course that staff have obligations right across that whole trajectory to intervene to reduce the harms, essentially, across that trajectory. I just want to draw your attention as well to the note about the sugar advisory. So even in the early work by Bowers and others, and a shout out to the service user and carer group advising on research, Professor Alan Simpson at City University in the 2000s had set up this reference group. And certainly many consumers do have an interest in this type of topic, and this was work that was in some ways guided, and particularly the interventions were shaped significantly by the consumer advisory in that work. Next slide, please. For us, we had consumer academic roles on the evaluation team. So when the Victorian state government invested in a very substantial implementation program, a significant but minority part of that spend was on evaluation, and we were successful tenderers for that, and we had consumer academic roles in our safe wards evaluation team from the get-go. So next slide, please. essentially, we conducted a mixed methods evaluation based on a fairly complex program logic, thinking about the stakeholders and what they wanted to achieve. And we particularly wanted to feature consumer academic evaluators when we were looking at consumers' experience of safe wards. And also our consumer academic team then actually took a step of leading some writing and some thinking on recommended enhancements. The program was driven by the Department of Health, and internal to government, there were also consumers, in the settings, in the clinical settings, they're consumer workers, peer workers and other consumer consultants on wards, and they got interested and involved in the implementation. But at the government level, the Department of Health employed consumer trainers for a rollout of safe wards training, and also within Anna Love, the Chief Mental Health Nurse's office, she had consumer advisors and a project team implementing and linking to policy. So there was a really significant consumer presence in the Safe Wards Victoria model that was quite distinctive. And I've just noted a caution there because in each case and right across these services, the consumer expertise was a minority, voice compared to the very vast amount of work and number of workers engaged in safe wards. And really the only piece of work, the consumer-led piece of advice around recommendations, is the only area that was consumer loaded, if you like. It was majority consumer work. And just the next slide, to drive this home, what difference that made, I think, to the diagram or to the model was that consumers, you could say, all over aspects of safe wards in Victoria as a result of a number of different investments at the level of government, service and evaluation. So obviously that the green highlighted piece is the work that we're doing. So what does this level of consumer perspective and various types of co-work mean for something like safe wards? Next slide, please. In our neck of the woods, we had a consumer lead investigator and involved in designing survey tools, conducting focus groups with consumer consultants and later with consumers in inpatient settings. And one of the papers that came out of the evaluation, the program logic and the evaluation, is this one. And yeah, it was quite striking that participants were very, very aware of safe wards. So whereas to some extent there's an emphasis on nurses' responsibility for doing things associated with reducing flashpoints, conflict, containment, actually consumers knew a lot about what was going on and had direct agency in 5 of the 10 interventions. Really relies on consumer involvement. And we found in our evaluation that people knew about the interventions and also could talk about some impacts for themselves, about feeling safer and about the relationship, the quality of relationship improving. And the consumer consultants were really observing some differences around what are quite modest interventions in safe wards. So that was really striking. There was a beautiful example of a discharge message that was observed when we were doing that, the focus group work. A discharge message, again, is one of the interventions, and somebody wrote, if inpatient, in their feedback, if you're an inpatient, you're in a dark place, then these things, discharge messages, bring you back to reality, safety and hope. So on the one hand, that was consumer perspective on discharge messages, which is a display on a tree. A different comment from our survey was, discharge messages are cliche and I won't contribute. So there was some really interesting nuance in the evaluation from a consumer perspective around what safe wards means and how it impacted people. Next slide, please. It's kind of, in a sense, a logical development, having people quite invested in consumer perspective, people casting an eye over safe wards so much, led to this interest in what more could be done, I think. And I don't want to speak any further really for the authors of this paper, but there is a sense of really taking the ideas forward. So in the findings of this paper, it's clear that consumers need more than the absence of restrictive practices, needing safety and sanctuary. There's no doubt, though, that something that makes a difference to restrictive practices does potentially reduce some of the most traumatic experiences that people have to take away with themselves from service use. And there was a caution there about interventions can potentially contribute to soft control. and that's important in a value sense for staff to be invested towards connecting and freedom and facilitating and allowing expression of distress. Those are sort of the goals that people might have. And there's also in Safe Words, as I mentioned, 10 standard interventions, but there's also a set of other potential interventions available in the original resources out of the UK. And these consumer authors reviewed those and selected that their preference would be for some of the interventions that really brought forward stronger relational practice around things like kindness, compassion, and also increased accountability. So it was interesting to see what was being valued, from that point of view and that particular expertise and sensitivity, I think. Next slide, please. So circling back to our friend Arnstein at this stage, drawing things together. You can see that, in Arnstein's terms, we're aiming high on Arnstein's ladder whenever we think about co-production. There's, the value in aiming particularly for partnership, potentially for delegation. And I think this maybe unpacking that concept of delegation. Delegated power is something that we see probably quite a lot, even in consumer-led work, where that work is in a sense sponsored within a non-consumer sort of setting. So it's enabled, made possible and facilitated, and therefore has quite a bit of independence, but that's a sense of a sort of delegated power, authority and resources, and citizen control, the whole concept of people standing independent from, and in a sense it's kind of beyond co-work at that point. So we're seeing some evidence of that, hopefully, and I'll be interested to hear feedback. I'm hoping beyond today people can reflect to me where they saw the strengths and weaknesses in terms of where some of the work we've talked about so far today comes from. Next slide, please. But in terms of it being a learning process, I just want to draw attention to perhaps some of the strategies that we have come to value and see as potentially important for strengthening the potential we have to do good co-work and to push ourselves up that ladder. One of the things that has been noted as there's an explosion in consumer perspective workforce is that some people find, and organisations find that people might not stay long, and there's definitely a sense of potential culture clash in people stepping into a whole host of different settings. And so this idea of having a welcoming culture, or really thinking about how we might generate a culture that's welcoming to lived experts, is just a very important starting point, and also never stops, because there are many things in organisations that maybe aren't all that welcoming of humanness in general. My sense has been that environments that are healthy for lived experience workers are often environments that are healthy for everyone. So sort of attending to our culture is something interesting to think about. Having people not isolated, not really organising ourselves around individual contribution and leaning very heavily. And here we are, we can say that. And there was a significant period of time when Kath Roper was in a standalone position, and props to her and to many people who have championed this work. But thinking about what a critical mass might be, what's a healthy sized group of people. Also, not just having people and sort of numbers of people, but also continuity and depth of team over time, being able to find pathways for people to stay connected, grow, continue in our work. Obviously, in a research environment that's often chopped up, we know that everybody has trouble with maintaining continuity of career path, for example. So this is challenging for everyone, but that team continuity. Thinking about how we invest in co-work relationships, and so it is about people, but also spending time with people, and coming back to some of those principles in co-production, those Cahn's principles, valuing the relationship and working actively on it, especially when we are talking about diversity. Sometimes building relationships across diversity, not in our comfort zones, isn't something that kind of happens as easily. And obviously it is possible to tread on toes, we all do it. But yeah, being invested in those relationships, but also in skill development. So knowing that people might need whatever is needed to really thrive, and being able to offer that is also important. Technically having career pathways that make it possible for people to stay and also to grow and to become profs, in those roles. And the operational support point is an interesting one, which in fact, all these things I'd have to honestly say we struggle with ourselves, but operational support in an environment where you've got a marginal expertise of some kind, it can be incredibly useful to have other people with more common skills in filling aspects of, administrative work, other operational work, so that you can use your experts for the things that they are best at. And again, I think that's not always common in research environments, is that we're in a very DIY world where we do all our own tech and our own whatever. But thinking about that, I think, and providing solid operational support is another potential strategy to strengthen the pathway of co-work. So these are just a few thoughts of ours from that kind of 15 years of, I don't know, stumbling our way, if you like. Next slide, please. Okay. So here I am just thinking about where does this leave us, and thinking back to the series as a whole. We know that the language of public participation in research is now really positioned as a defining principle that guides research process. So, basically everyone must get on board. And, we've gone from thinking about inclusion of study participants to this, idea of co-creation and the collaborative benefits of that. And then even more thinking about empowerment. These are all concepts that are sort of present in broadly in the discourse. I was interested, though, to think about why is it that we as nurses have tended to take this up perhaps more than average. It does feel that way to me in the way I reflect the positioning of our team in the department, in the school, in the faculty. And one of the things that strikes me is that qualitative methods have been strong in nursing scholarship, and we've seen that across our series this year. The particularity of story and the power of an N of one, is important to us. And I think that means we are interested in relational inquiry. We're interested in experience. We're interested in meaning making. And I think a lot of lived experts have interests in common with us there. Nursing, has a long-standing reputation and strengths in phenomenology and health, which is, amplifying voice and meanings. And again, that might be a point of connection and a common starting point for these sorts of partnership methods. And we can advance that to sort of share the research space so that citizens speak for themselves rather than us on behalf of, which I think is happening in our discipline. I think it does require humility and innovative thinking, and those are both things I think that maybe as a discipline we're also socialised a little bit towards, but of course others non-nurses are doing these things too. I did think a little bit about costs to us. I think, there's a lot of been talk across the series about the fact that it takes time on both sides for consumers, whoever the citizen population is, and it also means that we're unseated as the experts that are leading things. And that is also takes a bit more time, just charging ahead as opposed to stopping and being willing to learn and to listen. As people with structural power, we are going to get it wrong, and we're going to have blind spots, and there's going to be some discomforts and frankly pain at times, and those are also tricky for everybody. But of course, on the other side, there is enormous value to us as nurses, I think, as clinicians, as thinkers, as researchers, as influencers of policy. We can really benefit from this. It's certainly much more powerful for advocating for valued service as a human right, and obviously, this kind of work resources communities as partners in health. I was actually thinking about our participating speakers this series, and I remember John talking about the way this work, in terms of its benefit, orients us to what's important, and it really communicates powerfully and memorably. That came across very much in John's talk. Leanne was talking about the way that it supports, sharpens our focus in terms of what we're doing, increases our relevance, the influence, the uptake of research in practice. Mai was reminding us that it streamlines or refocuses care provision, and also it advocates, it means we're advocating for equitable access as a human right, and really strengthens our commitment to that, and also really foregrounds partners in health, and in some ways takes pressure off people to be the solution, for nurses to be the answer and the doers, but to see people taking responsibility, taking control is in some regards can be a bit of a relief of burden. From my point of view, I think lifts our understanding, and I think it does help us to see blind spots and really helps to hone our skills. So there are many positives in it. Next slide, please. So yeah, even despite whatever might be the challenges, I think it is great to sit, finally with that sense of with a considerable value that this type of work offers us as nurses, as practice researchers, and as theoretical researchers as well. So there you go. I'm all for it, and I'm really happy at this point. Last slide to take any questions. Thanks for listening.
Thanks, Bridget. That was really very interesting and a comprehensive tour of your work over more than a decade, really, isn't it?
Yeah.
Well, we're waiting for some questions, but we don't have any yet. But while we are waiting for some questions, I thought I'd start by asking you a little bit about, I guess, building critical mass, because that's, and you've touched on that, and about bringing people into different environments to talk about different projects. And I guess people have different interests at different points in time. And so how, in terms of that engagement and sustaining that engagement, what have you learned about what's important to people become and offer their time and their ideas to the work? Is there sometimes people like to be academics and sometimes they have other roles? So interested in think there.
Yeah, well, I'll pick up just two bits of what you were asking about there, Marie. The second one first, that idea that people have other interests, or that people are curious but not necessarily sure, is this something I want to do? So yeah, having mechanisms for sort of sucking it and seeing, for your tacky description, but being able to try something at some level seems really valuable. And I think that's actually been probably strong across the series, that because there might be ways of involving people, or invitational sort of ways that give people exposure at kind of early footing levels, that's a really good way to sort of for people to think, gee, I could be interested in this. I still think there are some hard barriers, and often they relate to money. So if people are invited to do sessional things, then it might be something that they have to keep very much as a side hobby rather than as a made gig. So how do we create those very first roles that make people, make space for people to do some work, a substantial piece of work, but get all the supports they need? So that first, in a sense, of career rung, career ladder rung, that seems really important. And I don't say that there's fantastic ways to do it, but we've certainly found that creating fractional casual roles for people to come and to see what the work is really important, because it's actually mirrors a bit in nursing. People don't know if they really like research until they have a chance to try that, and some people really haven't had much opportunity exposure yet. They accept that they might read it, and so moving into that space and creating opportunities for people to do that with a fair bit of learning assumption, rather than expecting people to hit the ground running and kind of setting people up to fail. So having a learning space and a sort of first rung position, I can't say that there's fantastic ways to do it, but it's needed, definitely. The other thing is that I think it is really important that people have each other. So however we organise that, and I think people with lived experience are very good at organising themselves, for reasons of solidarity, but needing to have solidarity in some way, I think, is really, really important. So rather than perhaps people feeling like their best supports are clinicians, us, it's actually just so important to have peers, have others who are in a similar role. So probably, things like, those sort of research programs like you have in a PhD program or something, having spaces where people are just together with each other is very important. And, obviously having senior consumer academics is so valuable for, providing mentorship and things. But even if it were beginners together, I think that's more important than, for example, me buddying with one person. I think that's a weak arrangement and doesn't tend to work as well. So that's so far a couple of points that come to mind from what you're asking. Does that sound?
Yeah, and I guess feeding into that as well, there's a couple of questions from Mai as well. And Mai's asking about capacity building, and when we apply for grants like within big schemes like the MRFF or NHMRC, there's not a really good understanding of the cost and the time in particular. So I know that you're involved in an NHMRC big program of work. The time it takes to build those, and that obviously time costs. So are there any things that principles we can draw on, or thoughts about how we can convince funders more and be more proactive in that space to, highlight, and perhaps some of the articles that you're talking about, and really pitching that idea about the value add, what the difference, what's the impact of having the consumers, which is what you're talking about.
I think you're right that probably making the case more effectively and talking to each other so that we can do that, really pool our best ideas to make good cases to the funding groups would be sensible, because particularly the MRFF, thinking about implementation they're ripe for thinking about this is important. And I'm sure people, especially investigators like our series this week, this year, would know that other funding bodies are well ahead of Australia in that regard in terms of requiring a level of consumer participation and partnership as part of a research proposal or enterprise, but not necessarily resourcing it adequately is absolutely true across the board. So I've been talking to colleagues in the UK recently, because it's been part of policy there. You cannot submit a grant without talking about who are your end user partners, but not necessarily either resourcing that work well enough with numbers and personnel, or with even tools, some of the sort of training and other things, recognizing that that's going to be really important, making space for it. So I don't think we're worse off or better off than other parts of the world at this stage, but nobody's doing a terrific job. I think, even for us, it could be thought of as, a developmental investment inside universities. That's another bunch. We're another bunch of people who could be arguing for this, through our seeding programs, or, say social equity is a really fantastic resource to us. If I can just shout out, the Melbourne Social Equity Institute has probably been the strongest enabler of our capacity building for investigators, particularly with, the PhD program, but also seed grants and so on. That's probably funding wise, they've been the most useful. And it makes sense, because it is about equity. I think thinking of it in an equity lens, this is a group of people who perhaps, aren't going to have benefited from a whole lot of, other aspects of development and pathway necessarily. And especially if you want to increase our diversity even more and look at our First Nations perspectives as well in our consumer populations. There's intersectionally lots of people who have not been advantaged and should be given resources, be provided resources to really lift equity. So that everyone should have a centre like the Social Equity Centre. There's a starting point.
Well, you mentioned that. That's really interesting that you should talk about intersectionality, because of course we've had workshops in the Department of Nursing around, around fair work environments, creating inclusive workplaces and so forth. This is to support our students, but when we think of that, we think, nurses have a really important role to play. However, the power structures that exist with it, they're not singly influenced by, for example, your position in one sector. It might be gender, there might be many other elements that are impacting on how people feel. And certainly in academic environments, those things seem to compound. And I wonder whether you could comment on the education and training that might be available, or what would be a curriculum or some supports that are going to help uplift really at a scale, that is required.
Yeah, I think that, some of the critical methods and scholarship around discrimination, intersectionality is very useful. And I think probably most people who do this work would be quite familiar with those sorts of intellectual resources, given that we're an intellectual space, just because really it does require sensitizing, doesn't it? And that's where that sense of constant learning for those of us that are, inside an organisation and have the benefit of, maybe a continuing appointment or whatever, to feel some obligation to be well resourced in our understanding. It makes me think actually that we could be doing something like a workshop to think about better articulation of what's needed, and that again, that would be a kind of work that we could be doing with people, obviously from my point of view, mental health perspective, consumer academics, but also potentially it could be other say in social work, there's the MAVE group, the people involved in speaking from first person about domestic violence. If we had a number of groups where this issue of capacity, requiring capacity accommodation being well catered for in order to increase equity, to make the situation more equitable, I think we could probably, work up some nice pithy resources that we could then be using for things like grants, but also even for teaching and learning, proposals, innovation. So if we did, have a bit of a brains trust and some key, really pithy key sort of messaging that we could be using in a lot of our documents, that could be really useful.
Yeah. So that's a really fantastic point to end on, Bridget, and we're right on 7 o'clock, and I want to sincerely thank you for your presentation and reflections and sharing so generously all your ideas and the work of the centre as well and your colleagues. So thank you so much. And now we'll just conclude our talk for the evening. There'll be some post-event communications to come out around a survey, and also we'll be in touch really soon to talk to you about our 2023 event series. So thank you everybody so much for your time this evening, and stay in touch. We look forward to seeing you next year. Take care.
Thank you so much. Goodbye.
Bye.